thing, I know I've probably asked this before, but I just want to make sure I understand. With the long leg, I understand that you get medial rotation and the pronation, but at the hip, the hip still won't it compensate by externally rotating to try to make it shorter?
No, external rotation, we're not talking about the hip. We're talking about the innomina, we're talking about the femur, we're talking about the tibia and fibula, we're talking about the talus, and so on. We're not talking about joints. We're talking about the leg. So medial rotation, again, you've got to think of this in terms of reverse your primary and conjunct movements here. The movement that is primary with the leg length change when you're trying to reduce a long leg or lengthen a short leg, the primary movement is not flexion or extension. The primary movement is rotation. So if I rotate the whole leg down, that way, there, everything goes down. The innomina, the tibia and everything. So these are incongruent rotations. This is not the way the joint wants to move. It's not the preferred movement of the joint. Alright, if we say that congruent rotation to the neck is ipsilateral, alright, we can argue about whether it is or not, but we can say that. So if I side bend to the right, the congruent rotation is right rotation. Yeah? Does that mean that I can't side bend to the right and rotate to the left? No. It means it's not the way it wants to go. So if I rotate to the right, if I side bend to the right and rotate to the right, I get that much movement. If I side bend to the right and rotate to the left, I get that much movement. Doesn't mean to say the movements can't occur, but they're incongruent rotations. So one side bending takes up, let's say that the two movements have 100% between the two of them, alright? And I'm interested in rotations. Well, if I take up the rotation or the coupled movement, 100% with rotation, I'll have maybe 80% rotation, 20% side bending. If I take up the side bending, I get 80% side bending and 20% rotation. Yeah? So there's a congruent movement and an incongruent movement for each one of these. This is the same thing. This isn't about, I know where you're going with this. If I want to extend the hip, then I'll do that. And the conjunct rotations of hip extension is extension and medial rotation. Is that okay? But if I rotate the tibia, the femur, then the normal movement that it wants to do is to extend the hip. So I'll take up most of the movement of extension rotation with rotation, and there'll be a little bit of extension of the hip. Is that okay? But it can't do that because at the same time as I'm doing medial rotation of the femur, I'm doing medial rotation of the innomina. Is that right? They're incongruent rotations. It means that the hip can't go into full medial rotation or full extension. These movements are jamming up on each other. Nonetheless, it doesn't stop it from trying to do that. So what you've got to do is actually, the easiest thing to do is to stop thinking about the joints when you're doing this. Just ignore them completely. If I extend and immediately rotate the innomina, that movement, then it's going to tend to extend the hip. Oh, sorry, flex the hip. Is that okay? Yes or no?
We're talking about thinking.
If I anteriorly rotate and medially rotate, that is, extend and medially rotate the innomina, then it will tend to flex the hip.
Yes.
Yeah? If I medially rotate the femur, it will tend to extend the hip. Yeah?
Mm-hmm.
Now, I can think about this, and I can think about it rationally and reasonably, but I don't really see the point. If I ignore the hip joint entirely and just look at what the leg's doing, because this is what we're talking about, is shortening the leg, then everything becomes simple. I can work my way through what's happening in the joints. I can talk about the congruent and incongruent rotations and the physiological movements that are tending to occur at the joint, but it doesn't really do much for me. But I can work my way through it, but I can't see the point. You're not convinced?
I think I'm just stuck, like I remember in a class years ago, they just said if you want to make your leg shorter, the patient's going to try to externally rotate the hip.
There.
And that's what I'm thinking of.
Okay, what they're going to do is laterally rotate the leg.
When you're saying leg, you're talking about the whole...
The whole quadrant. The innominate, the femur, the tib fib, the ankle, the subtalar joint, the intertarsal joints, and the toes. Everything will try to laterally rotate to lengthen the leg, if it's short. That movement. They're doing that, basically. And the foot's laterally rotated by inverting. Is that okay? Or not? What's the problem?
I'm just going to have to accept... I'm just...
No, you don't. If you don't understand this, you won't understand the rest of it.
To me, externally rotating the hip shortens it. Is that...
No. No.
Because you're trying, and then as you're trying to...
It's not the hip. Look, if I do that, there is no lengthening or shortening of the leg. Not appreciably. There just isn't.
Okay.
That, look, if I stand like that, I do that, has my leg got longer or shorter? That movement.
It's the same.
That movement, if I keep my foot flat, has that lengthened it or shortened it? No, I need the weight through it to do that. Now that leg's got short. Now that leg's got long. And the reason is because I've got ground forces squeezing this up. If I do that, my body weight is going through it, the ground force is pushing up through it, and the leg's getting... If I do that, which tends to pull the leg up, I've got to keep the foot on the floor. So my foot stays down there. Let me think about this one. If I stand, no, I get the same thing. If I stand on a trampoline and do that, what happens underneath this foot to the trampoline? Keep your weight sort of level and do that. What's happening to the trampoline underneath that foot? Hmm? Yeah, it's like if I stand here, I'm indenting the trampoline. If I do that, what happens to the pressure on my foot?
Not as much.
No, it goes through this leg instead. As soon as I do that, my weight shifts over there. So this foot pushes the trampoline down, this foot pushes the trampoline, as the trampoline come up. I don't stand on a trampoline. So this floor is unyielding. So when I do that now, my weight goes through there, and this leg actually starts to lift off. If I do it in this position, I don't have to worry about keeping the foot on the floor. Nothing's happened.
Okay,
Yeah? So stop thinking about the joints. Stop thinking about the femur. It's the leg that you're interested in. And the joint mechanics become more complex here because everybody talks about the conjunct movement. Lateral rotation of the femur tends to flex the hip. Not if at the same time I'm extending the hip, it doesn't. And I can perfectly well do that. I can do lateral rotation and extension. I just can't go as far into extension as I would do normally, but I can certainly extend it. I can do that, and I can do that. The movement is ultimately controlled by what you want the joint to do, what you want the bone to do. So it's your muscles that ultimately control this. There are preferential movements, but they're mostly artificial. Now walking's different. If I walk there, yeah, that leg's medially rotating, but the thing that's occurring is not the medial rotation. I'm not walking by doing this. What's occurring is I'm extending, and now the conjunct rotation has become important. So it's that. So when I step forward, I heel strike, the leg's actually rotating. As I come over the leg, the whole thing now starts to medially rotate. Till I come off that toe. But that's being driven by extension. This isn't. This is being driven by me having to adapt my legs to the surface. Or changing my posture on the surface. So the best thing you can do is not to think in terms of bones and joints, but think in terms of the leg. Okay?
Mm-hmm.
Anything else?
Yesterday you were talking about that the TL junction is like most likely too far away from.
To create leg abscesses.
Yeah, but what if you have like a signal facilitation to the hip flexor itself and you can't
No,
extend?
I said direct. Now, we're talking about direct effects, mechanical effects from the thoracolumbar junction. The direct mechanical effect from the thoracolumbar junction is minimal on leg length. The indirect effects, different argument.
So like cause versus diagnosis.
No, hang on. You can't throw a new argument at me and then use the old one as an example of why what I said was wrong. What I said yesterday was that the direct mechanical effects from the thoracolumbar junction weren't sufficient to create significant changes in leg length. I said what it will do is basically amplify, or could amplify, the effects of the leg length discrepancy. Now, if you want to talk about indirect effects, it's actually not the thoracolumbar junction, it's a bit lower than that. But if you want to talk about increased tone in the flexor muscle of the hip altering leg length, then yeah, but again, it's not going to be that great. How can it change the tone? How can it change leg length? How does increasing tone in psoas increase or decrease leg length?
Or could decrease the extension of the hip? And then it would like you technically alter that leg.
Okay. Yes, but if I'm standing there, it's not going to do much, is it? If I've got tight, okay, I'm talking about psoas, it won't change the leg length if I'm standing still. It will create extension loss, but that's older than that. But standing still, what it would do is increase lordosis in the spine rather than shorten the leg, and the reason is the leg can't lift off the ground. But yeah, I mean, basically, yeah, it could do it through that, but not mechanically, and that was my point. And that was the question that was asked. Yeah. How would you treat that, by the way?
We check for segmental dysfunction, treat that, and then
With hypertonicity from a thoracolumbar dysfunction, how would you treat that?
treat the dysfunction.
Yeah. So again, this isn't a matter of treating the facilitation at all. It's a matter of treating the dysfunction and then the facilitation will go away.
But something like that, you would definitely do like some movement patterns, contract relax the muscle to help it relax.
Before the manipulation?
Or before and after, basically after, right?
Yeah, but that's not to get the muscle to relax. That's to re-educate movement.
If the muscle's hypertonic,
It'll go away when I get rid of the cause of the hypertonicity. If I can't manipulate or mobilise the joint because of hypertonicity, yeah, then you defacilitate it. But what I don't want you doing is going around stretching or relaxing muscles just because they're tight. Get rid of the cause of the hypertonia. And it's no different from me saying don't strengthen weak muscles. Get rid of the cause of the weakness. Now, if it's structural, the only way you get rid of that cause is basically by tearing the crap out of it. You can do that, so you're left with trying to hypertrophy what's left in the muscle. But with non-structural weaknesses, don't strengthen the muscle. It's not really weak.
could you send that person home with like contract relax exercises of the hip flexor just to keep them in a more normal?
They'll stay normal as long as they're not getting nociception. I don't need to do that. If I've done my job right on this dysfunction, I don't need to do that. And if I do need to do that, it's not going to last. It's all based on the dysfunction. There is no point, as far as I'm concerned, in sending patients home with range of motion exercises, segmental dysfunction, or stretching exercises, or defacilitation exercises. I just don't see the point in this. Because you're either doing your job properly, or you're not, or you can't. If you can't, you need to figure something else. If you're not, then do your bloody job properly. A range of motion exercise is something that's always bothered me. Why do you a patient, you manipulate the AC joint, you've recovered the elevation, and then you send them home with elevation exercises. What in God's name for? What's the purpose of that? We do it all the time. What do we get from it?
Well, if they haven't moved their arm in a while, don't muscles get strong in certain. If they continue to go to 90 degrees, their muscle can be pretty strong at 90 degrees, but they're not.
No. Why is the muscle weak above 90 degrees?
They haven't used it up at that at that range.
So you've got structural weakness in those muscles?
Well, above 90 degrees.
It's structural?
Probably pain.
Well, it's inhibited, I guess, from pain.
Well, not after I've manipulated the bloody thing. I've got rid of their pain, so then it's not inhibited from pain. So why now are we giving... And it's, you're talking about weakness of the muscles, and I'm talking about range of motion exercises. Does range of motion exercises strengthen muscle?
You're saying, Jim, that you would rehab the moving pattern?
Yeah, rather than do this,
Right.
do it properly. This is rehab work now.
Right.
So
Versus
that's
maybe
doing range of motion exercises. I mean, usually the answer, you've been with me too long now, usually the answer is, well, you know, it may get stiff again. How the hell is it going to get stiff? You've manipulated the joint. This isn't a stuck joint, but it's not a stiff joint. There's no adhesions, there's no inflammatory products. I've got it moving. Why would it become stiff again? The only reason it becomes stiff again is if it subluxes, and that's based on lack of control. But at the time, they've got control. You just bloody give them control back by inhibiting this. Or defacilitating. You give them control back, but to give them the repeated range of motion, especially passive stuff, makes absolutely no sense to me at all. You've got to be looking at reasons why you're prescribing exercises. Actually, let's do this as a exercise. List all of the reasons why you would give somebody any sort of exercise at all. Write down what exercise it is. Don't write down every exercise, you know, but what type of exercise it is, and then what are your reasons to give them that? Okay, pathology is dealing with. This is rather great because the one thing we should get to do as therapists is prescribe exercises. Look at physical manipulation, listen. How are we doing? Ready? Alright, give me an exercise. You can either give me a generic type or just give me an exercise.
Pulleys.
Hmm?
Pulleys.
yeah.
Pulleys, okay. Alrighty. What conditions would you use them on?
Frozen shots.
Frozen shock, okay. Anything else?
Post-surgical.
Post-surgical, anything else? There isn't this interesting. Why wouldn't you use it on patients with full range of motion? Both of those things have limited range of motion. Why wouldn't you use them on patients who have full range of motion? So it leads on to the next question. What effect are you looking at to get from What are you looking to get from these exercises? What effect?
For this population?
You haven't given me any others.
Yeah. To do something. To read the bodies.
You could argue to mobilize the joint at their end range.
That's it.
But they can.
Actually, it can't. What's stopping them from getting more movement? Yeah. So this is going to mobilize their joint.
Well, you can hit the pain barrier.
Do they reduce the pain with this exercise? At the end of this exercise, are they less painful when you lift their arm up?
When you lift their arm up?
Well, when they lift it up.
Sometimes.
Well, actually, usually they're not painful. They'll stop before the pain hits them.
Yeah.
So, yeah, it's going to have to be, do you actually improve their condition? Is there reduced pain on your testing, and do they have increased range of motion after this exercise? Now, they've been sitting there for how long doing this?
I haven't stood there for 15 minutes.
Yeah, okay, so this is 15 minutes sitting there. What do you get from it? What's your result from doing this?
I've had people get, because they can't handle having somebody on their shoulder post-surgically as much, I'm like, then just go to the pulleys and they'll be significantly better with their active range of motion after the pulleys versus...
They still doing this?
No.
What do they do when they lift their arm up?
I mean, they're lifting it into high reaches. I mean,
Are they doing that with it?
Yeah,
So it's coming out.
there could be some tension.
Yeah, so what you're doing is you're aggravating the bad movement pattern.
Right, and then, but at least there's some, we're thinking about the population of people that don't do anything at home, like you had mentioned. You know, they don't want to do anything, they come in here, and the only time that they're going to do anything might be through some method of...
Okay, so we got the odd one that does that.
What's that?
We got the odd one that does that.
Yeah.
Alright, we got them sitting in the chair 15 minutes and the odd one they improve not the pattern of movement but their range of motion.
Yeah.
Okay. Is this the best way of doing it?
I'm sure there's other ways of doing it.
Well, why don't you talk this one?
Other movement strategies.
Now, well, this is my point. Why are you picking this? You did, but suddenly came up with pulleys.
Yeah.
Why do the pulley exercise? Because what you end up seeing is this, don't you?
Yeah, some degree. Yeah.
Why can't they get their arm up any further than that? And it's not pain.
Right, I agree. Like in that case, that obviously is a poor movement pattern that you don't want to continue to.
And that's exactly what happens with pulleys. You keep on doing this, and there should be a decrease in pain, providing you're not aggravating the hell out of them, because what you're doing is putting more mechanoreception. So if we go back to gait control, and it's not an accurate model, but it is. If you go back to gait control, you will decrease pain if you increase mechanoreception without increasing nociception. So providing they only go, I mean, you don't even have to go that high, you can probably do it there and get the same effect. So what you're doing it for is pain modulation. And this is my point, you need to know what you're going for. Now if you're going for pain modulation, is it an effective way of doing it by sitting in a chair for 15 minutes practicing bad movement patterns?
Sure.
Well, what if you're telling
That's
them?
effective and efficient.
What if you're telling them to keep their shoulders?
Have you tried telling people to keep their shoulders down?
Yeah.
How does that work for you?
Well, I stand there and I keep telling them to put it down.
And does it work?
Yeah, sometimes.
You're telling me that they start like that and they end up doing that?
Well, I use that thing that you were talking about, like pulling.
So you're not telling them, what you're doing is retraining movement.
I mean, it takes a while for them to get it, but
Yeah, no, but the point is, do you need the pulleys to do that?
no, but it gives
No, you're
them,
doing it so they can do the pulleys better.
Yeah. But it gives them a way to practice the motion over and over again.
It does, but you don't need to. Why the hell can't they do it actively? And if you want to do an assisted exercise, and you want to do this at home presumably?
Yeah.
Have they got pulleys at home?
Some of them buy them.
Do they have pulleys at home?
No.
Or do you give down exactly? But you can do this with a broom.
Yeah, or a stick.
Yeah. But if you want to take it home with you and you want to extend the training, why do pulleys in your clinic? What you're talking about is an active assisted exercise. Okay, it's an active assisted exercise when it's done properly, when it's done improperly. It's a passive goddamn exercise. This isn't simple, is it? If you're going to use pulleys and you use them properly, this is not easy to do. It makes it inefficient. What do you use it for mostly is parking the goddamn patient.
Would you use it for people with full range of motion, like your nerd?
Well, why not? This is my point. Why do you only restrict this to people with limited motion? We can, you're trying to use this as a training tool, retraining tool, then why not do it when somebody's got good ranges? And that, I'm not sure it's the best way to do it, but why not do that?
With pain.
Well, they've all got pain. But again, you've got to avoid the painful ranges, otherwise just make things worse.
But that would be the reason you would do it.
Well, I'd rather them do it PMF patterns. Although this is functional. But I'd rather than be doing PMF patterns because it's got more general application.
So what I'm thinking of too though is, let's say, I'm thinking of, my older woman with a shoulder replacement, anterior scar, pulling on the scar, the effect of having her being able to just unload that arm and move, maybe activate that muscle with the pulley, being more effective than her trying to lift it with a broom, or any other strategy.
Yeah, granted that this is an active assisted, the broom isn't.
Right.
I've got no problem with doing exercises for pain relief.
Right, okay.
But let's call it what it is.
Sure.
This isn't about improving movement patterns as much, and it isn't, unless you're doing what you're doing, and you'd be better off not using the pulley anyway.
I agree with you on that.
So this isn't about increasing range of motion. It's not about stretching things out. It's about relieving pain and done properly. And the problem is you can't do that with a pulley. Yeah. Done properly, you could retrain movement. But I still don't know why you limit it to restricted shoulders. In fact, the more pain they've got, the better off you'd be is not using this. I'm consistent. See, what it is you don't want to stand there and do it for them, or help them do it.
Well, yeah, or, like I said, it depends on, sometimes I've had people just respond better to female therapists because they think that they just see me over the top of their shoulder and they think they're gonna like.
Well, that's a whole different argument.
Well, yeah,
But rather than putting on strength, you'd be better off helping them do it. You can guide the movement, you can do all sorts of stuff that the police can't do. What it is you don't want to stand there and do it. You're like me. You want to go and do something to get the hell away from them, so you park them on a pulley system. UBE is exactly the same bloody thing. These are all parking devices because you could do better. I think it must be Dave. Is that you digging over there, Dave? Is that you digging?
Yeah. I do a little dancing.
But it really is just parking patients.
Yeah.
It's like a bike. You stick them on these goddamn bikes and you come up with all fancy ideas in the world, and what you do is you let them work while you're doing something else. Or, even worse, not doing something else, drinking coffee. But it does have uses.
Yeah.
And if I've got somebody who's exercising well, then why not put them to you can in that 20 minutes and do this, but it's got to be done properly. Personally, if you're going to do that, it's not a pulley, it's a pulley system. So you've got a grid and you can work these patterns with them rather than just mindlessly going up and down. Okay, give me another exercise. So this is really for pain and done properly.